So this DMECO risk stratification is something which you'll have to, as I mentioned earlier, remember it by heart. Even in the middle of the night, if I wake you up and ask you, should be able to mention. Okay. Please remember, the PSMA PET is not really required for low risk or very low risk. Because metastatic workup is not required for these individuals. Does that mean that you should never do it at all? You can do it if you want to. For a low risk or a very low risk patient, if you are going to offer the patient a radical prostatectomy, though it is not an indicated one, if you want to offer the patient radical prostatectomy, you should do a PET CT beforehand to make sure that you don't miss anything else. Is that clear? Otherwise, by and large, it is not required. What is intermediate and high risk category? You have a patient from T2B to T3, T4, and PSA of 10 above 10, okay, and more than 20. So that will be intermediate and high risk. Okay, next. For these individuals, you need a PSA PET. Next slide. The next slide, please.
Yes, sir.
Surya.
Yes, sir.
If you have a patient with an organ confined prostate cancer with no other metastasis anywhere else in the body, what are the options you have? We'll classify prostate cancer as localized and locally advanced, then metastatic. Metastatic, hormone refractory, non-metastatic, hormone refractory. How to manage each of these? What are the options you have in there? Okay, so that way we will discuss today. This will be a comprehensive overview. Okay, so management of localized prostate cancer. What are the options you have? Organ confined prostate cancer, I mentioned earlier. You don't do anything at all, just put them on a follow up. Offer them radical prostatectomy, offer them radiotherapy, and in select cases, you can give androgen deprivation therapy. Multimodal approach with adequate patient counseling will be the bottom line here. Next slide. We talked about active surveillance as the first option, which we discussed last week also, the PRIA study. Go back to the previous slide. The PRIA study. PRIA study is a Dutch study, which is one of the largest studies done for patients with active surveillance. And we saw that we had a follow-up of about 7 long years with serial needle pricks for PSA estimation, multiple biopsies which are being done to see if there is any upstaging of the prostate cancer. So all that rigorous protocol that they have to go through. So active surveillance for a low risk disease, though feasible, extremely difficult to maintain in a scenario like India where patients do not follow up, they abscond, they don't come on time. You call the patient 3 months time for a repeat PSA, they'll come in 6 months or 1 year time, and then say that the disease is advanced. Extremely difficult for you to treat them. So if you want to offer active surveillance as an option to the patients, number one, you should be in a setup where you'll be able to maintain the patient's details of who are all on active surveillance and to call them if they don't come back to it. And second thing is patient's motivation factor also plays a major role. In a center like ours, where we get patients from all parts of the country, all parts of the world, tertiary care referral center, patients come from Meghalaya, Sikh patients come from Iraq, Tanzania. Extremely difficult for you to put them on active surveillance because it's not possible for them to come to you every 3 months for 7 years' time. In which case, active surveillance is not an option at all, even if it is a low risk disease. Please remember, active surveillance for low risk disease is an option only if you can put the patient on active surveillance. If the patient cannot be put on active surveillance, radical prostatectomy will be the treatment of choice, even if it is a low risk disease, organ confined disease. Is that clear? Yes or no?
Yes, yes, sir.
Yes. Okay. So what radical prostatectomy? Again, it depends on what you are trained in. Maybe a local. It may be It may be open. It may be laparoscopic or robotic assisted, robotic. Whatever you do, radical prostatectomy, removal of the prostate gland, surgical removal of the prostate gland is the treatment of choice for localized or organ confined prostate cancer. Active surveillance, you will say only in select instances where the patient is willing for the active surveillance, and you are in a setup where you can follow them up actively. Because active surveillance, as I had mentioned last class, the difference between active surveillance and watchful waiting is that in active surveillance, both you don't do anything at all. In active surveillance, you follow them up in such a way that if at all the patient upstages to for the higher grade or higher stage, you can always offer the patient a treatment with curative intent. You will be able to treat the patients aiming at cure of the disease in patients who are subjected for active surveillance. On the other hand, patients who are in watchful waiting, if the disease progresses, You can only give them a palliative care. You cannot offer the patient curative treatment. Okay, that distinction you should be able to make between active surveillance and watchful waiting. So active surveillance is indicated only for low risk disease in whom patient is willing for a follow-up and you are in a position to follow them up. Otherwise, radical prostatectomy is the treatment of choice. Either radical prostatectomy or IMRT, radiotherapy in the form of intensity modulated. Don't say brachytherapy, don't say external beam radiotherapy. It is IMRT. IMRT is one form of a brachytherapy where you target only the prostatic tissue. You target the prostatic tissue in such a way that you identify the areas which need more attention and you hit those areas with more radiation. That is called intensity modulated radiotherapy. You don't give standard dosage of radiotherapy to the entire prostate gland. You identify the areas which need more radiation, identify them, target them with higher radiation cover. So that is why it's called as a conformal radiotherapy or also called as intensity modulated radiotherapy. And then androgen deprivation again in very select instances. Don't say that for all patients with organ confined prostate cancer. Basically, what you should say in the exam is that you sit down with the patient, talk to the patient all possible options, and together along with the patient, you will take a decision which is called as a shared decision. Next slide. You will take a shared decision. So that's very important. Shared decision making is very important because always the patient should be understanding what you are going to do, what you are going to talk about. Otherwise, there is no point. Okay. So that's something which you'll have to be very, very careful about. In a patient with localized prostate cancer, before you put the patient on active surveillance, I said number one, the patient should be willing. Number two, infrastructure that you have should be able to monitor them closely. Okay, only then the patient can be subjected for active surveillance. What is Epstein's criteria? Epstein's criteria is one criteria which is very, very commonly used tool to see who are the candidates who can be put on active surveillance. I said localized to prostate cancer. Organ, it may be organ confined, but if the PSA is 20, will he be a candidate for active surveillance? So there should be some criteria to define the patient to be fit enough for active surveillance. So what are the criteria? Number one, that is remember that is PGDCP. It's very easy mnemonic to remember PGDCP because I'm saying PGDCP because there's another mnemonic which I'm going to talk about next. Easy to remember that also if you remember this. What is PP is PSA levels. The serum PSA level should be less than 10. The Gleason's grade, G stands for Gleason's grade. The Gleason's grade should be less than 6. That is 3 plus 3. Mute, please. And then D stands for PSA density. PSA density should be less than 0.5 nanogram per ml per gram of tissue. That is D, PGD. P for PSA, G for Gleason's grade, D for density, and then C for number of cores positive. How many cores are positive? Less than 3 cores, more than 3 cores. And the percentage of each core that is positive. Less than 50%, more than 50% of each of the cores that are positive. These are the 5 parameters based on which you will decide whether this particular candidate is fit enough for an active surveillance or not. Please remember this. Okay, even if it is a localized prostate cancer, if the PSA level is more than 10, if the PSA density is more than 0.5, or the Gleason's grade is 4 plus 3 or 4 plus 4, they are not the candidates for active surveillance. Please remember this. This is the data which came from the prior study. Those patients with the Gleason's grade of 4 plus 4, 4 plus 3, who were put on active surveillance, they all progressed very rapidly, in which case they had to intervene. So it is always better that you choose the patient for active surveillance. These 5 criteria should be fulfilled before you put the patient on active surveillance. PGDCP. P for PSA, G for Gleason's grade, D for density, C for number of cores positive, and final P for percentage of each of the core that is positive. If it's more than 50% core involvement, that means highly unlikely that this patient is not a candidate for act. Next slide. So these 5 parameters you should remember. And once you feel that this candidate is not a candidate for active surveillance, if you feel that he has to be subjected for a radical prostatectomy, then you should apply this particular score called the Capra score. The Capra score will tell you whether this patient will have a successful procedure done, whether he'll have a cancer-specific mortality, which is significantly negligible, and whether there'll be a recurrence after surgery or not. So all these parameters you will take into consideration to decide on whether this particular, next slide, please. Next slide. Yes. All these criteria, there are 5 criteria again which you will take into consideration before you decide on the need for a radical prostatectomy. Because you do a radical prostatectomy, the outcome should be good. If the outcome is not good after radical prostatectomy, what is the point in subjecting this patient for such a major procedure, isn't it? The 5-year recurrence-free survival and the cancer-specific mortality should be predicted before you offer any form of a major treatment to the patient. Okay, what are the 5 parameters that you take? Sorry. Okay. So what are the 5 parameters in Capra score? Earlier I said for Epstein's criteria, PG-DCP. Here it is PG-ACP. Okay. Remember like that, PG-ACP, ACP, Assistant Commissioner of Police, or whatever. Deputy Commissioner of Police, whatever. You should remember PG-DCP and PG-ACP, you should remember. Okay. PG-ACP is what? Capra score. Capra score, the 5 parameters here are P and G are the same, PSA and Gleason's grade. There it was PSA density. Here they take age of the patient into consideration. And then the clinical, C for clinical, there it was core positive, number of cores positive. Here the clinical stage, whether it is T2B or T3A or whatever T stage is the patient, the clinical stage, and the percentage of positive cores. P for again percentage of score. So here, there it is D and C change, here A and C change. Otherwise, the other 3 parameters remain the same. And then you give a score for these 5 parameters, give a score from 0 to 10. Go back to the previous slide. Okay. So these are the 5 parameters which take into consideration PG, ACP, and each of the scoring is given. Capra score is given from 0 to 10. And if supposedly you have a patient who is 60-year-old male, okay, age of the patient is 60 plus, okay, and PSA 8.5, T2B, read about it, okay. The Capra score, the higher the Capra score, next slide. The higher the Capra score, the greater the possibility of having a higher risk, okay, of surgery and the poorer outcomes after surgery. So the Capra score should be less than 2 for a patient to have a good outcome after surgery. The Capra score, if it is more than 6, the outcome will be very poor here. So first whenever the 5 parameters that you take into consideration will be as per the D-amico risk stratification, where you have taken 4 factors into consideration. One is the D stage of the individual, one is the serum PSA level, and then the Gleason's grade, and then the number of cores positive. These 4 parameters you take into consideration to risk stratify them, put them in low risk, intermediate, and high risk category, and then plan your treatment accordingly. Once you have identified that these are the candidates who are low risk category, then you apply Epstein's criteria to see if they are amenable for active surveillance or whether they are candidates for radical prostatectomy. That assessment you should do. Once you have decided that they are not candidates for active surveillance, once you have chosen radical prostatectomy as a treatment option for localized prostate cancer, then you have to apply a Capra score to see whether they are in the low or an intermediate risk category or the high risk category. So if they still fall under the high risk category, the prognosis or outcome will be very poor here after radical prostatectomy also. So that assessment you should be able to make. Is it clear?
Yes, sir.
Once you have decided that you are going to do a radical prostatectomy, depending on the age of the patient, depending on the performance status of the patient, depending on what you can do to the patient, depending on what the patient wants, depending on the erectile potential, these are the variables which you have to take into consideration before you decide on the type of radical prostatectomy that you can do. Type means not approach, I'm saying. Approach can be open, it can be robotic, it can be laparoscopic. Type means whether it is intrafacial, next slide. Whether it is intrafacial, can you zoom it a little more? The one on the right alone, you can zoom it a little more. Yes. Good. Okay. See, there are 3 types. One is intrafacial, one is interfacial, a third one is extrafacial. What do you mean by intra and interfacial and extrafacial? In relation to 2 fascia. One is a prostatic fascia, one is a denon-villus fascia. Can you show the prostatic fascia here, Surya? See, the prostate gland is lined by one pseudocapsule. Okay. The pseudocapsule is drawn as a black line here. All around the prostate gland, there is a pseudocapsule which is closely abutting the parenchyma of the prostate. That is a pseudocapsule. The next closely abutting pseudocapsule will be the prostatic fascia, which is drawn in a brown line. Okay. The brown line is
Prostatic fascia, sir.
Prostatic fascia. And then beyond that, you have a denon-villus fascia, and then you have the rectum outside that. Okay, so there are two fascia which you should remember. One is a prostatic fascia, the other one is a denon-villus fascia. An intrafacial prostatectomy is one where you create a plane between the brown line and the black line, prostatic fascia and the pseudocapsule, and enucleate or scoop out the entire prostate, leaving behind the prostatic fascia intact with the patient. That is intrafacial. In intrafacial, what happens is that the neurovascular bundle is, show me the neurovascular bundle with arrow. Yes, sir. Neurovascular bundle is largely remaining undisturbed here. Okay, that is intrafacial. Interfacial is one where you create a plane between the prostatic fascia and the denon-villus fascia and remove the entire prostate gland, scoop out the entire prostate gland along with the prostatic capsule and along with the prostatic fascia. Okay, the prostatic pseudocapsule and the prostatic fascia are removed along with the prostate gland in interfacial. Interfacial means between the prostatic fascia and the denon-villus fascia. Interfacial means between two fascia. Interfacial means between prostatic fascia and the denon-villus fascia. In which case, the prostatic fascia will be removed along with the prostatic pseudocapsule and the prostate gland. That is called as interfacial. Here again, the neurovascular bundle is damaged or not damaged here?
Not damaged.
Not damaged here. So in interfacial, again, the prostate neurovascular bundle is not damaged here. So these are nerve sparing prostatectomies. The interfacial and the intrafacial radical prostatectomies, these are nerve sparing. The third one is along with the neurovascular bundle, you do a prostatectomy where it's an extrafacial where you create a plane outside the denon-villus fascia, scoop out the denon-villus fascia along with the prostate so that you're not worried greatly about preserving the denon-villus fascia. If it is preserved, let it be. If it is not preserved, you don't mind injuring the neurovascular bundle. Take it out along with the neurovascular bundle. That becomes a nerve non-sparing prostatectomy. These are the three types of radical prostatectomy. It can be replicated in robot. It can be replicated in laparoscopy also. So what is done open can also be done simulated with the robotic. So the approach I'm not talking about. It is not the type. It's only the type of radical prostatectomy that is interfacial, intrafacial, and extrafacial types of radical prostatectomy. Next slide. All this about the locally organ confined prostate cancer. Now we move on to the locally advanced prostate cancer. By definition, locally advanced prostate cancer is one where there is either a seminal vesicle involvement, T3P, or in one disease where there is a regional nodal involvement. In which case, what do you do? There is no single treatment for it. There is always a combination treatment. If there are only very small nodes, if there is a mild obliteration of the lateral septus, and if the radio investigations confirm that there may be some infiltration of the seminal vesicle, and if you have the confidence that you can remove the seminal vesicle en masse along with the prostate, then radical prostatectomy can be planned in the primary setting, okay, with extended pelvic node lymphadenectomy. That can be done, okay. That's something which you'll have to remember. Radical prostatectomy for locally advanced disease can be done with external pelvic lymphadenectomy in very, very select patients. Or by and large, you can give external beam radiotherapy or androgen deprivation therapy for longer term, 9 months, whatever. And then there are certain hormones which come in, whatever, not required. So locally advanced, you should remember that if you believe in radical prostatectomy with the pelvic lymphadenectomy, if you think, again, there are three types of seminal vesicle infiltration that you should remember. Number one, seminal vesicle can be infiltrated. That is called a Wheeler's classification. WHEELER. Wheeler's classification of seminal vesicle involvement in patients with radical prostatectomy. Number one, there can be a direct contiguous spread from the prostate onto the seminal vesicle. That is number one. Number one, it can go directly from the prostate gland. It can directly infiltrate into the seminal vesicle. Number one. Number two, from the prostate gland, it can go through the prostatic ducts. From the prostatic ducts, ejaculatory ducts, the seminal vesicle into the seminal vesicle. So that is the second type, that is a ductular spread. The third type is from the prostate, breach of the blood prostate barrier, gets disseminated, goes into the circulation, and from there it reaches the seminal vesicle as a metastasis. So that is the third type of seminal vesicle involvement. The first type is direct contiguous spread, second is a ductular spread, and the third one is a hematogenous spread. All three types of spread have got their own significance. In patients with localized prostate cancer, where there is a direct contiguous spread from the prostate gland onto the seminal vesicle, you will have an obliteration of the lateral sulcus. In which case, if you can do a prostatectomy with the removal of the seminal vesicle and extended pelvic lymphadenectomy, that can still be aimed at cure. Or what you can do is you can give the patient neoadjuvant chemotherapy, downsize the nodal mass, downsize the seminal vesicle infiltration, and then you can do a radical prostate, whichever you believe in, you can do. Okay, the next slide. So basically, what you should remember is for a locally advanced cancer, there is no definite radical prostatectomy be done with it. Not there. It should always be associated with the supplementary chemotherapy. Next slide. Combination therapy. The third one is a metastatic prostate cancer. This is what we discussed now some time back also. The metastasis can be a lymph node metastasis. It can be a bony metastasis. Patient's primary treatment will be a hormonal treatment. Androgen deprivation treatment will be the primary treatment, with or without channel TRP. You can do a androgen deprivation in the form of surgical castration or a medical castration. And along with that, you will also give the patient androgen receptor, okay, blockade. That is bicalarabine also will be supplemented with that. In patients with a high volume disease, you can add chemotherapy to that. In patients with bony involvement, you can add some monoclonal antibodies, whichever you believe in. Believe in abiraterone, we discussed all that. You can try abiraterone, you can try docetaxel, prednisolone, estromycin, hydrochloride, methotrexate, bisphosphonates as supportive measure, and then the monoclonal antibodies. Next slide. All this can be tried also. Okay. And then you should know about the oligometastasis and non-oligometastasis. All these are very important for you. You should know about the charter trial. You should know about the latitude trial. Everything you should know. I don't think we'll have time for all that to be discussed. But what I said and done, at least this much you should know. Management of oligometastatic means if you apply the charted criteria, less than 5 metastasis, no visceral involvement, no lung involvement, no appendiculoskeletal involvement. If there are less than 5 bones which are involved, axial skeleton, but in addition to that, if there is a visceral involvement, or in addition to that, if there is an appendiculoskeletal involvement, then that becomes a high volume disease. Okay, non-oligometastasis. Next slide. Finally will be the hormone resistant prostate cancer. We discussed all that again. Here, abiraterone comes into picture here, enzalutamide, apaletamide, docetaxel, carbitaxel, cabazitaxel, all these are the other, and then various other immunotherapy, radionuclear therapy. All please read about all these things. But what you should remember is that it should be Schroeder's regime or stepwise regime where you take one step at a time, start with the lower things, and then you go to the higher generation medicines. Okay, drugs. Okay, so that should be the basic. Do you have any further slides after this?
Yes, sir.
Okay. Can you run through the slide, Rajan?
Yes, sir.
No, no, the previous one. No, no. Post RP.
Yes, sir.
Yes, this will be a summary of. Okay. Somebody was asking, how do you follow them up? No. Okay. So you have done a radical prostatectomy today for a locally organ confined prostate gland. Done such a beautiful surgery, and you are following up 6 to 8 weeks. So after 3 months, you can give. 3 months will be the ideal time where you repeat SRMC, because the first 4 to 6 weeks there will be some surgery related complications. There may be some bleeding, there may be some urine leak. All that will take some time to settle down, and wait for about 4 to 6 weeks at least. Never do anything at all. The third month you will repeat a serum PSA and see how it is. After radical prostatectomy, the serum PSA should be negligible. It should be undetectable. You in fact have to do an ultra sensitive serum PSA estimation to actually detect the serum PSA levels. Okay, that should be the level of serum PSA after radical prostatectomy, because PSA is almost exclusively, not fully exclusively, almost exclusively produced by the prostate gland. Though there are certain other places where PSA can be synthesized, that's all very negligible quantity. So if you do an ultra sensitive PSA, it should be in undetectable levels, less than 0.001, like that. So PSA level at 6 weeks to 3 months should be done. Okay. If the PSA is undetectable, just leave it like that. Every 3 to 4 months, the first year, repeat a serum PSA, and then up to 3 years or 5 years, you will repeat it every 6 months. Follow them up. Okay. If you have done a fairly good job, and if you have done a curative radical prostatectomy, the PSA level should be undetectable all through. And if there are no other micrometastases elsewhere at the time of radical prostatectomy, the PSA levels for the next 5 years should be normal, and then you'll have to annually follow them up with serum PSA for the rest of the lifetime. Okay, this is one entity where everything goes without a problem, no nothing at all. Operation is successful, patient is happy, you are also happy. But on the other hand, in 3 months' time, when you do the serum PSA, the PSA levels are still high, not undetectable. What does it mean to you? It means number one, you have not done a fairly good surgery. That means you're left behind some residual lesion. Or number two, there is inadvertent metastasis which has already occurred, which has gone unnoticed at the time of radical prostatectomy. Isn't it? These are two possibilities that you can think of. One, there can be a local remnant, not recurrence here. There can be some sort of a local remnant or some residual lesion at the site of you have not done a complete removal of the prostate gland, left behind some apical tissue, possible. It's something which you'll have to remember because the PSA level has not become undetectable after surgery at all. Or there is something else which you have missed out in the rest of the body. That there is some metastasis which has gone unnoticed. That has to be identified. That has to be treated with systemic therapy. The next slide. No, previous slide. Okay, keep it here. If supposing the PSA level has become undetectable, and then when you are following to the patient 3 months, 6 months, 9 months, 1 year, whatever time, and then suddenly the PSA level is more than 0.2. The definition of biochemical recurrence after radical prostatectomy. Biochemical recurrence after radical prostatectomy, by definition, PSA level of more than 0.2. That is a definite value to call. This is completely in contrast to the PS biochemical recurrence that you get after radical radiotherapy. We'll come to that later. Next slide. Here, for all practical purposes, if you have a patient with radical prostatectomy being done, if the subsequent PSA value is more than 0.2, that means it is biochemical recurrence. That's the definition of biochemical recurrence after radical prostatectomy. Whereas biochemical recurrence after radical radiotherapy will be if you have a patient with radiotherapy done. The radiotherapy will not bring the PSA levels to undetectable levels immediately. It takes about 1.5 to 2 years for the PSA level to settle down because with radiation there will be some inflammation, with radiation there will be some edema, with radiation there will be some breach of blood prostate barrier, with radiation there will be some sort of a collateral injury to the adjacent structures where healing will not take place properly. So PSA levels become unpredictable in the first 18 to 24 months. So if at all you want to call it a PSA rise, that will be only after 2 years of radiation therapy. Until then, extremely difficult for you to make a diagnosis of a biochemical recurrence. That's the reason why this Astro definition, the Phoenix definition, had so much of ambiguity because of the presence of what is called as a PSA bounce, which will happen in between. You'll be under the impression that the PSA levels are falling, but later you'll realize that at 18 months, there will be a sudden jump in PSA level, which you will think as a biochemical recurrence, but actually it will be a PSA bounce. This PSA bounce actually happens between 18 to 24 months of time, where there's a transient rise in PSA, and then the PSA level falls back to the original level, pre-bounce level. So biochemical recurrence after radiotherapy, usually by definition, is different from the biochemical recurrence definition after radical prostatectomy. So the Astro definition you should be very familiar with. The Phoenix definition again you should be familiar with. These are exclusively for post radiotherapy biochemical recurrence. Whereas post radical prostatectomy biochemical, next slide. Post
சரி
radical prostatectomy biochemical
இங்க
recurrence.
பாரேன். நம்ம ஒரு புக்கு தான் படிச்சோம், இன்னொரு புக் படிக்கல. எடுத்து
யாருப்பா? Okay. So the biochemical recurrence after radical prostatectomy is more predictable. That's the reason why they have a fixed cutoff as 0.2 here. There is no serial rise, consecutive rise, and all comes secondary there. Anything above 0.2, when it has especially become undetectable, becomes a biochemical recurrence. The management of HRPC. How do you treat it? Can you zoom that a little, Surya?
Yes, sir.
Hormone refractory, hormone resistant prostate cancer. Come to one side. Okay. Then you should see, first criteria will be, number one, you should make sure that your castration levels of testosterone are achieved or not. The castration levels of testosterone means it is less than 50 milligrams, nanograms per deciliter. Okay. That is the cutoff that you should remember. The testosterone levels, especially after surgical castration or after medical castration. The next follow-up when you do with serum PSA levels, you should also do with serum testosterone to see if the castration levels are achieved here. And then you look at when the PSA levels are going up, see whether it is a hormone refractory prostate cancer or not. And if it's a hormone refractory prostate cancer, see whether it is a metastatic or a non-metastatic hormone refractory prostate cancer. Address it accordingly. Again, it's just a juggling of various, you juggle around with various drugs that are available. You have palutamide, enzalutamide, darolutamide, flutamide, bicalutamide, which we commonly use. And then you can use the other drugs. And then you have abiraterone acetate also as one of the main drugs. If that is not adequate, then you can switch over to docetaxel and prednisolone. That's all. And then give supportive care to the bones and other things. Okay. That is the way you treat a non-metastatic CRPC. Next slide. See, if supposing you have a scenario where the PSA is 3000 here, you want to do channel TRP, like in our patient, it's we had a big nodal mass which you want to treat along with the treatment of the primary prostate cancer. In addition, if you find that this patient has got a big lesion in the vertebra, you said spine and cranium are normal, but if supposing there is an acute tenderness at D10, D11 vertebra, and then you do imaging for that and find that this patient has got a bony metastasis, how do you proceed now? Yeah.
High dose. So high dose radiotherapy. High dose steroids.
No. First thing, if there is a bony metastasis, you should see whether it is osteoblastic secondary or an osteolytic secondary. If it is an osteoblastic secondary, this rule of thumb does not apply.
Yes.
If it is osteolytic lesion, because most of the time CA prostate is osteoblastic secondary. You all know why CA prostate has got osteoblastic secondaries?
Yes.
Why?
So because the bone seeking agents, the osteopontin and osteoproteinectin, it will seek the bones and it will form sclerotic bone.
They will get very good. They will get seeded on the bone. That is called as Paget's theory or seed and soil hypothesis. The seed and soil hypothesis is one where there is osteopontin, osteoproteinectin, these two agents which are secreted or produced in excess by the cancer cells of the prostate gland. They have an affinity for axial skeleton. They will go and get themselves seeded. So bone marrow becomes the soil. This osteopontin, osteoproteinectin becomes the seed. So these seeds will get sown on the soil, and that is the reason why they produce metastasis in the long bones. Okay, and these metastases usually are osteoblastic because osteopontin and osteoproteinectin they'll produce osteoblastic secondaries. On the other hand, if there is a lytic lesion in the bone, if there is an osteolytic metastasis, that is the time when you'll have to be a little careful about which one to give priority for. Do you need to give priority for the lytic bone or do you need to give priority for the bone, the prostate gland? That distinction you should be able to make. If supposing this patient has got a lytic lesion in the weight-bearing bone, that's the scenario I gave you now. If this patient has got an osteolytic lesion in the weight-bearing bone, if there is a lesion in the weight-bearing bone, see whether it is osteoblastic or osteolytic. If it is osteolytic, look for the area of lytic lesion. If that lytic lesion is more than 50% of the cross-sectional diameter of the bone, or if the lytic lesion is more than 2.5 centimeters in length, or if the lytic lesion involves the length of the cortex equal to or more than the cross-section of the diameter of the bone. That means the lytic lesion burden is higher. That means the bone becomes very fragile and more prone for fracture. That is what it means. If it is more than 2.5 centimeters long, or if it is more than 50% of the cross-section of the diameter of the bone, that means the bone is more likely to break while the patient is on treatment. So what will happen if there is a bone which is breaking there? The spinal cord will get compressed. Or in other words, if there is an impeding cord compression, then again that takes the priority. If supposing the patient has had a previous radiotherapy given to the same area of the lytic bone earlier for some other reason, then again that takes the priority. Okay. So in such instances, the bone takes the priority. You have to surgically fix the bone before you initiate definite treatment for CA prostate. Because you keep treating CA prostate with surgical castration, channel TRP, and pectoratum and all. By then, if in case this lytic bone breaks, there will be quadriparesis or paraparesis depending on the level of injury, and that will produce more harm than good to the patient. So, in such instances, if there is a lytic lesion which is more than 50% of the cross section of the diameter, more than 2.5 centimeters long, or if there is an impending cord compression or previous radiotherapy given to that area for some other reason, then the bone has to be fixed first and be started on high dose glucocorticoids, dexamethasone high dose 8 milligram IV up to 24 milligrams can be given every day. And high dose glucocorticoids will reduce the edema and inflammation and also give you some analgesic benefit also. Treat the bone first before we treat the prostate gland. Next slide. Okay, and then the indications for MPMRI. Indications for MPMRI. The indications are many. See, general dictum is that if you believe in the concept of MPMRI before trust, you can do that. That is how it has become these days. But for exam point of view, if they ask you, you cannot say this. You have to say that if supposing the patient has got an elevated serum PSA or abdominal DRA, plus you want to do an MRI guided, it's a fusion biopsy or targeted fusion biopsy that you want to do based on the precision trial. So, based on the PROMIS trial, MRI, MPMRI, and MPMRI targeted biopsy scores our trans biopsy. In which case, if I have the state of the art facility in my setup, it is always better to go for MPMRI. You can argue it out that way. No problem at all. And for localized cancer, if you want to assess the local staging, MPMRI will be definitely helpful because they'll give you details about the capsular involvement, seminal vesicle involvement, neurovascular bundle involvement. All this can be done with a higher accuracy than with your transrectal ultrasound. Those patients on active surveillance, you want to put them on active surveillance, pirate score of 1 and 2, putting them on active surveillance, in which case you can do serial MPMRIs to see whether they're progressing to pirates 3 or 4 or 5, plan accordingly. That also you can do. For treatment planning also read about. By and large, MPMRI is not the investigation that you will tell the first sitting in the exam, unless or otherwise some centers which do MPL, like for example, you have Apollo, DNB candidates from Apollo for that matter, they routinely do MPMRI here. So that though if your institutional protocol is like that, and all the PGs from that particular center all speak the same language, then you can always say MPMRI the first sitting as long as your internal examiner will come to your defense. Otherwise, to play it very safe, it's always better to go for a transrectal ultrasound and a trust guided biopsy first and then take it from there. The next slide.